Hello, everyone. I'm Dr. Yan from Shandong University from China. And today, my presentation is about the pitfalls in pre-implantation genetic testing of monogenic disease. So we know that PGT-M refers to testing for nuclear DNA pathogenic variants causing monogenic disorders with an autosome dominant, autosome recessive, or X-linked transmission pattern, but also mitochondrial DNA pathogenic variants. It also refers to exclusion testing and to ESHRE typing with or without concurrent testing for monogenic disorders. So my presentation today will discuss the pitfall from 5 different areas: small families, expand carrier screening, small number of embryos, early dropout, and parent mosaicism. Now we come to the first one, small families. We know that for all diseases, samples should be collected from the prospective parents and close relatives with known disease status to establish the high risk and low risk of haplotype. For dominant disease, it is recommended that one affected individuals and or one unaffected individuals should be collected as a reference. And for recessive disease, at least homozygous or compound heterozygous affected individuals, one carrier and one non-carrier individuals as a reference. And for X-linked disease, unaffected individuals must be used as a reference and or one unaffected individuals. So if the families is not big enough, we cannot get the enough information from these families, and we cannot draw the right conclusion. So when no suitable family members are available, the informativity analysis should be performed in the couple, and the segregation of the high risk and low risk haplotypes established during the clinical cycle. For some cases, it will not possible to determine the high risk haplotype during workup. For instance, when the de novo pathogenic variant is present, or when no relevant family's DNA samples can be obtained. So in these cases, it may be determined during the clinical cycle based on the result from the biopsied embryo cells. As shown in this figure, high-risk haplotype is determined during the clinical cycle based on the result from the biopsied embryos. From the embryos, we can compare with the parents, and we do SMP linkage analysis, and we can find the correct result. So the second pitfall is expand carrier screening. Expand carrier screening, we call it ECS, is extend panel testing for hundreds of genetic disorders with a broad range of phenotypes. ECS allows couple to consider the complete range of reproductive options for preventing the birth of children affected by genetic disease, including PGT-M, prenatal genetic testing, or the use of donor gametes. So we must be aware of the challenging and the limitation that may come with a positive result. So before the patients come here and what they want to do the testing, we should told them, given the number and the heterogeneity of the conditions included in panels, it cannot be guaranteed that a couple who test positive for one of those conditions will be eligible for PGT-M, because we can't always do, or we can't do everything for the positive result. And we know that family history is typically lacking in these couples. So with the advent of NGS, cases of couples in which one member carry a disease causing variants, and the other has a variant of uncertain significance found in the same gene are likely to become more common. And these need to be discussed from the PGT-M perspective. So with comprehensive panels, where healthy individuals are likely to be identified as carrier for several conditions, testing of carrier status for embryos and prioritization of the embryos to transfer needs reaccessing. So ECS plus PGT-M package cannot always be told or always be offered to the couples who want to do the ECS because not every time or not each result can be tested by the PGT-M, or we cannot always draw the right conclusion. In particular, with the best interest of the patient as our primary concern, we should refrain from offers that bring nothing but increased cost and anxiety. So as shown in this table, it was shown that not only did the majority of at-risk couple identified through ECS alter their reproductive decisions based on the results, but there was no significant difference between the rate of action between severe and profound disease currently recommended by professional society and those not yet included in screening guidelines. That means the couples who got a positive result, most of them always to want the doctor to exclude the risk of the embryos, to exclude the risk of the offspring. So they not always obey the professional society's advice. They only want to do PGT-M. So they got some shortcomings. The third pitfall is small number of embryos. Also, we know that enough embryos always is good for the doctor to draw conclusions. The more embryos, the more correct results we can get from this test. When unaffected embryos are not produced following IVF with PGT-M, some patients maybe they want to request to transfer embryos with the positive test result. So the majority of transfer were for embryo positive for adult onset reduced penetrance diseases. As this request will likely increase over time, it is essential to consider the practical and ethical implications. For some patients, for de novo pathogenic variants in a prospective parents, when phasing of at-risk haplotype is unknown at the start of the clinical cycle, it is recommended to biopsy and analyze unfertilized oocyte and embryos that are not suitable for biopsy, so we can get more information for further analysis. Ideally, at least one affected embryos and one unaffected embryos are needed to establish the correct phase and detect recombination events. So it is not possible. It is recommended to cryopreserve the embryos and to wait for the analysis of embryos from the next cycles. So if the embryos is not the number is not big enough, we do not have enough embryos, maybe sometime we will give the couple the advice for cryopreservation of the embryos for the next cycle. So the first pitfall is early dropout. The limitation of low DNA quantity are related to the increased risk of either DNA amplification failure, DNA contamination, or the phenomenon of ADO. ADO means one of two alleles in a heterozygous sample is amplified while the other remained undetected. So this is often more challenging for single cell analysis compared with analysis of few cells. So based on this, 5 to 10 TE cells biopsy are encouraged. And the WGA step followed by downstream applications such as PCR, SNP array, and NGS can be used to detect the pathogenic variants and more genetic markers for haplotype confirmation to avoid ADO. So the WGA-based strategies are mostly coupled with TE biopsy. And if we do this, which often leaves insufficient time for fresh embryo transfer. So this is they need cryopreservation and embryo transfer in the next cycle. In this figure, it shows the ADO of the pathogenic variants can be detected by using more genetic markers for haplotype. The last pitfall is parental mosaicism. As generalized mosaicism due to post-cycled de novo pathogenic variants in the prospective parent cannot be excluded. It is not recommended to use unaffected child prenatal embryo samples as phasing reference. If mosaicism has been detected, the transmission risk has to be evaluated. Generalized mosaicism detected in the prospective patients, parents can be an indicator of somatic mosaicism and vice versa. So following single cell analysis is not recommended to transfer embryos that carry the wild type allele for the pathogenic variants, locus, and the high-risk haplotype because of the ADO risk. It is acceptable to transfer such embryos following analysis of TE samples. Of course, prenatal diagnosis is always strongly recommended. So this figure shows somatic mosaicism detected in the prospective parents can be an indicator of germline mosaicism. As shown in this picture, we can find this embryo. This embryo with the wild type allele for the pathogenic variants, locus, and the high-risk haplotype. For de novo pathogenic variants in an unaffected child, an initial evaluation of the couple's reproductive history may provide evidence of potential germline mosaicism in the parents. For example, through evidence of recurrent transmission in previous pregnancies. If DNA from previous terminated cases available, the case can be dealt with as an ESHRE PGT-M protocol. So further evidence of potential germline mosaicism in the parents may come from evaluation of the pathogenic variants in various parental tissues. So that's all for my presentation. Thank you for your listening.